Okay, everyone, we'll go ahead and get started. Let me change this to the slideshow, and we are recording, just to bring that to your attention, in case others could view this later. All right, great. Can everyone hear me okay?
Yes.
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 Okay, great. Perfect. Okay, great. Well, good afternoon, everyone. And my name is Jennifer Kastner Thomas. I'm the Code Director here at SENTA Partners. Thank you for joining us for today's Lunch and Learn, where we're going to discuss the Global Surgery Package. Before we dive into the content, let's quickly go over a few housekeeping items. First, this webinar is being recorded, so we kindly ask that all participants please mute your phones and computers to reduce background noise. And to ensure that we're able to cover all material during this designated time frame, we will be taking the questions related to the presentation at the end of the session. Also, the information that we're covering today is current as of today and may change with new information or clarification released by CMS, the AMA, or any of the Medicare administrative contractors. Any questions related to this presentation can be directed to me, Jennifer Kastner Thomas, at jennifer.kastner@sentapartners.com. During today's session, we're going to cover a few key areas related to the Global Surgery Package. First, what is the Global Surgery Package? Next, what services are included, meaning not separately billable, and excluded, meaning they can be billed separately. We're going to discuss the preoperative and postoperative visits. And then we're going to briefly discuss common modifiers that are used during the Global Surgery Package. And then finally, I will turn it over to you guys with questions that you may have related to this topic. To get us started, let's look at two key definitions that we're going to mention numerous times throughout this presentation, starting with the global period. This is the time frame for which specific services are inclusive to the major procedure and cannot be billed separately, which is also known as unbundling. So this brings us to unbundling. As just mentioned, this is when you bill for services separately that are included, and this is not allowed. I recently watched a YouTube video from a popular coding influencer. Her name is Victoria Mole. You may have heard from her, and she explained this perfectly. So I'm going to use her example. When you buy cake from a bakery, you're purchasing what's included in that cake: the eggs, the flour, the time to bake, the frosting. Everything is included. We would not pay for a cake plus the individual items from a bakery. So that pretty much sums up. It was a perfect example what she described. So what is the Global Surgery Package? This slide reflects the components of that package, which includes the preoperative services, the surgery itself, as well as postoperative care. Therefore, if a provider is providing all of these services to a patient, it is subject to the Global Surgery Package, which is one payment. And you will not bill for the pre and postoperative visits individually using the E&M codes. And I do have a couple of slides toward the end that gives directions on how to post those cases. Also want to point out that all providers within the group, they are all an extension of each other. So this still applies even if the nurse practitioner or one of the other providers within the practices is providing a portion of the service. These same rules apply. You guys, they are all an extension of each other. So you would not break up these services and bill them separately. Over my years of auditing, one of the top errors that are usually identified within chart reviews for surgery relate to billing preoperative and postoperative visits. And especially when the global code was billed. So for the next few slides, I'm going to break down the components of the Global Surgery Package, as well as what services are considered inclusive and exclusive. But first, let's talk about this slide. This slide goes over the different global surgery periods, which are composed of 0-day, 10-day, or 90-day global period. I want to point out for 0 and 10-day global periods, these are classified as minor procedures, and they are subject to Modifier 25 rules. This information was covered during last month's Lunch and Learn and is available within the Cornerstone Learning module titled Mastering Modifier 25. So starting with the 0-day postoperative period. This includes like endoscopies and some minor procedures such as the ear cerumen removal. For these services, there's not a preoperative period and no postoperative days. Additionally, an E&M visit on this day is not typically separately payable unless there are unique circumstances, and that must be reflected within the documentation. Next, we have the 10-day global period. This includes other minor procedures. A good example is like a skin lesion removal. For these services, there is also no preoperative period, and an E&M visit on this day is not separately payable unless there are unique circumstances that are met and documented. Also, it states it's a 10-day global period. However, it really is 11 because you count the day of the procedure and the 10 days immediately following. Again, I highly recommend you go check out the Master and Modifier 25 to really get the specifics on those because there is a little bit of different rules there. Finally, today, what we're going to be talking about is mainly the 90-day global period, and this is for major procedures such as septoplasties. For a 90-day period, the payment that is received includes one preoperative visit, and this is usually for that H&P, the history and physical, where they answer questions about the surgery, sign consent forms, and they do the history and physical. That visit is inclusive to the surgery. And the surgery and the postoperative visit is also included. Also, the total global period is really 92 when you include the H&P visit, the surgery day, and the 90 days following the surgery. Again, today's session is mainly going to focus on those major procedures with a 90-day global period. On this slide, you can see the global split for CPT code 30520, which represents a septoplasty. As you can see, there is a 90-day global period for the CPT code. 10% of this reimbursement for the global surgery package for the service goes toward the preoperative services. 76 is allocated to the intraoperative services, and 14% is allocated toward the postoperative care. This information was taken directly from CMS Global Surgery Packet, which reflects all information that is considered inclusive and exclusive. I also included the link at the end of the presentation on this material so that you could go directly to that Global Surgery Packet information from CMS. So let's start with the services included. This means they cannot be billed separately. When doing so, Medicare considers this as abuse of Medicare funds and is subject to fines, penalties, and recoupment. The same goes for commercial payers. When not billing according to the coding policies and procedures, you're subject to payments being recouped when not billed according to those rules. First, we'll start with the first column, and the first thing mentioned is preoperative visits after the decision to operate. This means that once the decision for surgery has been made, that the subsequent visit to answer questions related to surgery, sign those consent forms, and the preoperative history and physical, those are included. Other services include the intraoperative services that are normal and necessary part of the surgical procedure, all medical or surgical services the surgeon provided during the postoperative period, unless it requires a trip back to the OR, follow-up post-op recovery period visits, post-surgical pain management, supplies, and miscellaneous services such as your dressing changes, local incision care, operative pack removal, sutures and staples removal, lines, wires, tubes, drains, cast and splints, insertions, irrigation, and urinary catheter removal, routine peripheral IV lines, NG and rectal tube and tracheostomy tube changes and removals. All of these are services that are bundled into the global payment. Now that we know what services are inclusive, we now are going to discuss the services that are excluded from the global surgery package. So this means that these services are not included in the global surgery payment and can be billed separately. These services include that initial consultation or evaluation of the problem to determine the need for the major surgery, visits unrelated to the condition that required surgery, and I'll cover that more here in a minute, underlying condition treatment, or an added treatment that's not part of the normal surgery recovery, diagnostic tests and procedures, including diagnostic radiological procedures, also clearly distinct surgical procedures that happen during the postoperative period that aren't reoperations or complications from the treatment. This slide reflects some other excluded services, therefore can be billed separately. Includes treatment for post-operative complications when the patient returns to the OR. If a less extensive procedure fails and the patient needs more extensive procedure, CMS will separately pay the second procedure. Organ transplant, immunosuppressive therapy. And the last thing noted is critical care services unrelated to the surgery, where a critically ill patient, seriously injured or burned, needs constant physician attendance. And the reason for that is in the hospital, sometimes there's that hospital follow-up after surgery is performed. That's going to be inclusive to the surgery as well. But if it's a critical care service, that's different because that's not typical care associated with the surgery. On this slide, you can see an important AMA CPT assistant article from May of 2008 where they clarified that H&P visits should not be billed. So let's take a look at this. But before I mention that, I want to point out there's a difference between the pre-op visit and a pre-op clearance. Pre-op visits are usually those, like I mentioned, you're answering questions, providers are answering questions, they're signing consent forms, they're doing that H&P exam, which is a requirement. That's inclusive. But a pre-op clearance is usually where maybe a patient is having surgery and they're being referred to a specialist to clear them, like a cardiologist, a pulmonologist. They want to make sure that they're good and healthy before they proceed with their surgery. And that's performed by an outside provider, not the one who's doing the surgery. So there is a difference between pre-op visits and pre-op clearance. And I just want to point that out. So let's take a look at this particular question. And also AMA CPT Assistant, they're a very authoritative source. This is what, when there's usually a lot of questions and a lot of gray areas when it comes to coding and auditing and these unique guidelines and rules. So CPT Assistant, they clarify a lot of those and those questions, and a reputable source for us to go to for clarifying that stuff. And a lot of payers also, they use this information when they create their rules as well. So go into this question. It says, example, hospitals require that we do an H&P within 30 days of taking a patient to the OR. If this visit is more than 48 hours prior to the surgery, is that a billable visit? CPT assistant says no, the H&P in this case is not a billable visit. And they explain that if the decision for surgery occurs the day of or before a major procedure and includes the preoperative E&M service, then this is separately reportable with Modifier 57. And I'll describe that here in a minute. I've got additional information on a subsequent slide on that. It's indicated, it's able to be billed to say that this isn't just a history and physical visit. If the surgeon sees the patient and makes a decision for surgery, and then the patient returns for a visit where the intent of the visit is the pre-op H&P, and the service occurs in the interval between the decision-making visit and the day of the surgery, regardless of when the visit occurs, whether it's 1 day, 3 days, or 2 weeks, this visit is not separately billable as it's included in the surgical package. And they gave us an example here. The surgeon sees the patient on March the 1st and makes a decision for surgery. Surgery is scheduled for April 1st. The patient returns to the office on March 27th for that H&P, consent signing, and to ask and clarify additional questions. The visit on March 27th is not billable as it is the preoperative H&P visit and is included in the surgical package. Again, as already mentioned, a portion of the reimbursement for the global surgery package includes the post-op visits. Your practice should schedule the post-op visits to occur prior to the end of the global surgery package timeframe, which is 90 days again for the major procedures. If for some reason the visit falls outside of the global period, for example, due to scheduling conflicts, you still should not bill for this visit because a portion of your payment for the surgery was allocated for this service. Post-op visits should be coded with CPT code 99024 instead of a regular E&M office visit such as 99212 through 99215. However, should a provider address any conditions unrelated to the surgery during the post-op visit, they could bill an E&M code based on the level of decision-making that is associated with the unrelated condition. and modifier 24 will be needed to prevent denials. Speaking of modifiers, this slide covers some of the common modifiers used during the global surgery package. Starting with modifier 24, this modifier is to be used for E&M services that are provided to the patient during the postoperative period for reasons unrelated to the procedure. This modifier should not be used for E&Ms provided on the same day as a minor procedure. Modifier 24 only applies to major procedures identified within the global period of 90 days. An example, a patient was seen during his post-op visit for a recent septoplasty, and during that visit, the patient also had a complaint of upper respiratory symptoms. If the provider treats the upper respiratory symptoms and the assessment and plan clearly reflects this work, an E&M service can be billed to represent the work associated with the respiratory condition. Any work related to the post-operative service for the septoplasty during the same encounter cannot be counted toward the leveling of the E&M service. Modifier 57, this represents decision for surgery when performed within 3 days of the surgery. I do want to point out that this is CPT's guidance, and Medicare has a different stance. Medicare will only cover this service if the decision for surgery occurs the day before or the day of. And just to give you a little rationale behind that, they see that as, again, it's more than just that H&P visit. There's more work that's being performed because an actual decision is occurring at that visit. And you should get paid for that additional work because, as it mentioned in the previous slides, the first visit to, making a decision that the surgery is even needed, that is separately payable. So the logic behind this is not only is that additional work, but there's also more work. If you're doing a surgery with 1 to 3 days, there's some urgency to it, and there's some medical necessity weight that just justifies being able to bill that visit, even though it's within just a few days of the surgery. So those cases where it's surgery is decided, especially the day of or the day before, Medicare will cover those. And we don't expect everybody to keep up with Medicare requirements and Medicare and commercials and who does what. I know that especially for providers, we want to leave that, trying to leverage our system and also our coders and billers to understand these rules. But that's something that just to be aware of, that a lot of times that, Medicare is a little different and there may be some denials because of their difference in opinion. Unfortunately, if all payers would just be on the same page with things, that was significantly reduce healthcare costs. But unfortunately, this is the rules for now. So just know Medicare has a little bit of a different stance when it comes to that modifier 57. Now, the next 3 modifiers, the modifier 54, 55, and 56, I've grouped them together to show that they are only used when there's a transfer of care in place, meaning that physicians of different groups perform different parts of the service. So modifier 54 is for surgical care only, meaning they're only doing the surgery. It could be a situation like maybe an emergency and they were on call and this is a new patient they've never seen them before and they're literally maybe they've made an arrangement with a physician to where they're going to break up care. Maybe they live in different localities and it's a convenience thing, or maybe it's just an arrangement between 2 providers, but there has to be an arrangement in place. But yeah, if they're only doing that surgical care only and they're not doing the pre-op visit and they're not doing the post-op visit, then modifier 54 would be the appropriate modifier for that. Modifier 55 is post-operative care only, and modifier 56 is for the preoperative management only. I've seen this in the past with ophthalmology. Like sometimes, this provider will do the preoperative care and they just send the patient just for the cataracts, and then they come back and they handle the post-surgical. So it's sometimes a unique situation. It may be based on unique surgeries, but just know that there is a different process for billing those services when there is a transfer of care in place and the surgical package is being split amongst different groups, not different providers, because remember, your providers within your group, you're all an extension of each other. So this is for different groups that are not part of the same practice. In these cases, both the surgeon will use the same CPT code. Both surgeons will use the same CPT code and the date of service with the appropriate modifier. And in the case where 100% allowable, the 100% allowed reimbursement, they will be split between the providers based on the portion they provided. So, like the surgeon will get 80%. It just depends on what service was provided. Post-operative, it may, going back to that original slide, it showed the breakdown. That's how their reimbursement will be split up amongst the different groups. Okay. So because of a lot of the global surgery, we talked about the minor procedure briefly, the 0 and 10-day global period, because we covered that last month, and there's a whole presentation related to the minor procedure. Again, that's called Master and Modifier 25. Highly recommend you go check that out. But because we covered a portion of that last month, this session's a little bit shorter. So just some general global surgery package takeaways when it comes to the 90-day global period. Remember that a percentage of the reimbursement for surgery is allocated to the pre, intra, and post-operative services. And you can refer to the image there for a reminder of how it's split. Pre-op visits, how should you bill those? AMA has not created a CPT code for H&P pre-op visits. So it kind of sets the stage where providers are very transactional. I provided a service, there should be a CPT code for that. And because AMA hasn't created a CPT code for pre-op H&P visits, it does cause like a lot of errors in the industry where providers they feel inclined to choose an E&M service. So because of that, just industry standards, I've seen in the industry where sometimes there's internal tracking codes that are created. That's what I recommend because you want to be able to track, especially if you have like nurse practitioner that's doing your pre-op visits and then the physician's doing the surgery. Sometimes it can make it look like the nurse practitioner is not being productive because they're not getting revenue for those pre-op visits because they're going to be bundled. So I personally recommend there being a tracking number or a unique CPT code or some kind of tracking mechanism where you monitor that so you can monitor the productivity for those services, like whether it be like pre-op or something like that. But I'm happy to have any of those discussions where we could create something like that. Otherwise, it just should not be billed. Post-op visits should be billed with CPT code 99024. Again, going back to the previous slide, unless the reason for the visit meets criteria mentioned in that excluded column, in that case, we can add that modifier 24, like in the example that I mentioned, coming in for the post-op septoplasty, but they also had an upper respiratory condition that was addressed. What you would do is you would build an E&M code with modifier 24 for the upper, and you would only put the diagnosis for the upper respiratory, link it to that. We wouldn't want to link the diagnosis code for the septoplasty post-op or anything like that to the E&M code because that tells the payer, hey, I'm trying to include the work associated with that in this E&M. And as previously mentioned, we have to exclude the work associated with surgery because there's already reimbursement associated with that. So we can't, it's kind of considered double dipping in the industry. So modifier 24 would be the modifier that we append in that case if there's work above and beyond that post-op visit. Okay, and then this slide represents all the references. Highly recommend you check them out because there's always hidden information. Stuff is always updated. You may find something also relevant to some unique questions that you have, but I am happy to answer any questions. I'm going to stop recording at this point, and then we will turn it over for any questions that anyone may have.